Medical disclaimer. Please note that the information shared on this podcast is for educational and informational purposes only and should not be considered medical advice. Always consult with your healthcare provider before making any changes to your health regimen, including starting new therapies, supplements, or treatments. While we discuss cutting-edge research and advancements in cellular medicine, individual health needs vary and professional guidance is essential. By listening to this podcast, you acknowledge that neither Dr. Seeds nor the podcast team is providing personalized medical recommendations.
On today's episode, we're going to dive into female hormones. We're back for another episode of Redox Revolution, and we're continuing the episode here on hormones in females. Matthew is here.
And female.
And female, our professional female,
Ooh,
Maddie.
Professional,
who
nice.
may be able to interject a little bit here or there. Who knows?
Probably just will.
Matt, take it from there.
I feel like I should ask Maddie the first question.
Oh boy.
Maddie, why are hormones so important in women's health?
Hormones are important in women's health because hormones are the key to our sanity. When
So
your
is-
hormones are out of whack, you're just out of whack.
So are your hormones just always out of whack or something?
Pretty much. Pretty much.
Well, I'm going to be careful what I say
Tread carefully.
with working with a lot of women in many of our businesses. But I respect that statement that you
you.
said. And I'm going to actually just make a little bit more out of what you said as far as I think that hormones play even a more significant role. Not that they don't in males, but estrogen, as far as estradiol, progesterone, and testosterone, I mean, they play a tremendous role in women's health. And there's no doubt they have a significant role in mitochondrial function and in cellular metabolism. They play a role in immunity. They play a role in cognition and in neurogenesis. They play a role in tissue repair and think of the endometrium, how the endometrium breaks down, and builds. That should tell you a lot about how important these hormones are, especially for females in recovery and repair. And
These hormones are key to growing a child inside of you. So that should tell you how important they are.
even more important. So Matt, this is a big topic, but I think overall, with what we just and of course redox and controlling inflammation and having an influence on redox is significant. So and it.
We talk a lot about peptides and how they're used as signaling agents.
Mm-hmm.
Do hormones work the same way?
So
That's a good question.
yeah, so this is kind of relates to what we were talking about before. Hormones they have the ability to go through membranes, cell membranes, and their job is to get to the estrogen receptors or the progesterone receptors or the androgen receptors that are in the nucleus to transcribe proteins and other signaling agents to activate, to do their job in the cell. So that's really important to understand that they're different from peptides that are more cell membrane based, where there are receptors that sit on the cell membrane to activate secondary messengers in the cell to carry out the signaling that may occur in the nucleus, may occur in the peroxisome.
So hormones go in where peptides are like surface
Correct.
level.
Now there are caveats. They're penetrating peptides. They're cellular penetrating peptides that can actually carry cargo into the cell. I mean, that's a very big research area right now with peptides that can carry messengers into the cell and specifically to the nucleus to help transcribe the appropriate messaging and stuff. So, very good question. And I think it's a very good distinction to understand.
Well, let's keep going with distinctions then. Between estrogen, progesterone, testosterone, should we clarify, like, do women need all of those? And what can lacking any individual one really cascade into?
Absolutely necessary, all of them. They're all very important in reproduction. Estrogen's very important in cellular metabolism, mitochondrial function, immunity in immune cells. It's very important in cognition, in brain-derived neurotropic factor, influencing brain-derived neurotropic factor. And it's very important in estrogen in bone health. We were talking about recovery and repair before about the endometrium. It's fascinating, that estrogen can play a role in the mitochondria in the neuron. And at the same time, it's important in the osteoblast in the bone, right? I mean, what a transposition there, right? For women, that's significant. So estrogen has the importance in bone metabolism. Progesterone, you can think of progesterone more as more brain involvement, more GABAergic modulation, more myelin.
So, what's GABAergic modulation? What do you mean?
It's working on improving. The best way, I think, for what you had brought up is it helps dampen excitability of the neurons so that you have better control of stress and anxiety, and you can go to sleep. Your mind's not racing. Issues like that. It's a significant player in the brain, in neurogenesis, in synapses, in improving synaptic plasticity. Testosterone is very important in recovery, repair, in bone health.
I feel like testosterone, is the one thing for females who are still having issues with libido, no matter what we've done and what other hormones we've optimized. Testosterone is usually the one we have to rely on to help with the libido.
Exactly, and it is very important for libido. Libido, and that's a big topic, by the way.
Do a whole podcast on libido.
Oh my golly, there you go. There's another podcast. And it's significant in it's also a very protective hormone that I think isn't given enough credit for what it does in protecting females from like breast cancer and things like that. That testosterone makes a difference in that respect. You could go many ways, but all three of them and how their ratios are, you got to really do a good job in maintaining the appropriate ratios of all of those in trying to get it try to get them dialed in as well as you can, because I think that makes a difference in how they continue to progress
What's the age range that things start to slide a little bit then for women, and what is happening inside of the cell? Not inside of the body. Let's continue with the cell. What's happening inside of the cell with these hormone levels, with the bioavailability you were talking about, the transport in? How does all that start? How does all that work?
Couldn't it technically be any age? Because, you have PCOS, you have endometriosis, which usually hits younger, and then obviously menopause and everything.
Yeah, there's a lot that goes into that and the possibilities and just what you said. I think generically, or if you're just trying to look at a large group, it's the mid-30s that things start to progress, and then
You're considered a geriatric pregnancy if you have a baby at like 35.
and then in your 40s there definitely is a progression. And then typically in the early 50s is when menopause can usually early 50s strikes, but it can strike in the 40s. We've seen it in younger. And its influences are significant from now the female has only so many eggs that she makes at the time of conception, and
Isn't that crazy to think about?
and those eggs are there forever, and it's not like they make new eggs. And so those eggs, and then what happens with the follicles and so forth, have an influence on estrogen and testosterone and progesterone. So there's inflammatory factors that can influence early menopause and can affect it from the HPA axis again, from the hypothalamus to the pituitary, which is the gonadotropin releasing hormone, from the hypothalamus to the LH and FSH, which we talked about in the anterior pituitary, and then how that influences the follicle, and specifically these cells called granulosa cells, thecal cells, and there's a lot to it.
But the LH and FSH, not that they don't matter in males, but LH and FSH, when it comes to females, aren't those more important things that you have to follow, because that goes through like your luteal phase? That's the only phase I know.
Smooth.
Well, it has an effect on progesterone and estrogen and also testosterone. So absolutely, there's a lot that goes into evaluating a female based on if they come in and think they're premenopausal. Just like the male says, I'm fatigued. It's usually the female comes in, it's more cognitive.
Brain fog.
What's that?
Like brain fog.
It's always the brain fog and then the central fatigue. It's more like a central fatigue than muscle fatigue. And they basically want to kill everybody in their family.
They don't feel great.
They don't feel good. So that is a thought process that starts a conversation sometimes that we have with the females. And it's, again, it gets back to what we do. And it's like, well, before we jump into this, but I'll say different than males, we absolutely, we do jump into it because I want to know precision processes that are involved in female metabolism of pregnenolone and progesterone and testosterone and DHEA and estrogen specifically. I want to know everything about estrogen metabolism because it plays a big role in, if you are going to go on to hormonal replacement. I just feel that you have to understand how they're metabolizing estrogen to really figure out how you're going to dial in the right amount of estrogen, and the fact that you have to know the metabolites, The important thing, let me just bring up something that I just don't think we pay enough attention to, and that's how estrogen is metabolized, where it's conjugated, it's hydroxylated, it's conjugated, and then it's eliminated. You've got to know these different steps of possible conjugated metabolites that increase cancer, increase autoimmune disease. And I mean, there's so many answers there that you can absolutely hone in on to find out why somebody's headed down the wrong direction. And if you're going in to correct their estrogen with just giving them estrogen and not looking at those processes, you may make them start to feel better initially, but you may be influencing more production of like that 16 alpha hydroxyl estrone, which is cancer. It's pro-proliferative. It's cancer inducing. Then you have these other metabolites that can do similar things or cause more inflammation. So you have to know if you're going to drive a system that way, and then you can keep people out of a lot of trouble and be very precise in what you're doing to influence estradiol or estrogen. And in fact,
To get those numbers and to see the pathways that they're metabolizing estrogen, it needs to be from the urine, correct?
yeah, it's a 24-hour urine. It's a difficult test. It takes a lot of work. It's not like an easy blood stick, and because you can't see any of that in a blood test. This is a detailed type of testing, and you also need to look at a lot of other things. You need to look at cortisol and DHEA sulfate and methylation, and because those are all parts of this process. And the one thing I wanted to say, I think you even have to be responsible, even if you feel that a female is doing okay with her hormones. I think you have to offer them still the ability to look at their metabolites, because you can have normal estrogen and normal progesterone, but the way they're metabolizing their estrogen could be bad, and creating what may be not interpreted in the blood as a higher estrogen state, or too much estrogen, things like that. There's a lot to the cellular medicine of, even more so with females, and I think that's just the crucial part. And and we spend a lot of time. We spend a lot of time on that, in letting them know how important that is to evaluate. But while we're doing that, we're focused on improving mitochondrial efficiency, improving metabolic flexibility. And my opinion on this is, I think, has resonated even further now that we've seen more physicians and patients have been exposed to this GLP-1 craze, which is working on efficiencies of mitochondria. We've seen how it's influenced reproductive health and female hormonal health. Mm-hmm. And that has brought attention back to, wow, maybe the cellular metabolism, maybe mitochondrial efficiency, I need to pay more attention to. And that's got me excited, because people are wanting to know more.
So for females, I feel like when they're getting ready to start hormones, or even asking about going down that hormonal route, they have so many apprehensions because of all of the previous research and studies that were done where you take estrogen, you're going to get breast cancer.
No, that's that 2002 study.
I have it right here in 2002.
Always got on that.
The Women's Health Initiative study. That's the one you're talking about, right?
Yeah.
And so it was a large study of hormone replacement therapy in postmenopausal women. Reported that there was a significant increase in breast cancer and stroke in women taking estrogen plus progestin HRT. The study also found no benefit for reducing cardiovascular risk. This led to the premature termination of the estrogen plus progestin arm of the study and a significant decrease in the use of HRT among women. Like you said, the study was greatly flawed. Key flaws were tied to the study participants being older, overweight, and long-term postmenopausal. The study's emphasis on relative risks rather than absolute risks, combined with the misrepresentation of statistically insignificant findings, also contributed to a misleading perception of HRT's risks.
Which took over 20-some years to come out, and it set women behind tremendously. And that was the battle we were fighting from day one, all of us, and the misconceptions there.
But there's still, I think the doctors and like some OB, like there are still providers who are following those studies and telling patients, no, absolutely not. Like you need to get off your hormone replacement therapy.
Well, that's why it's great. Like, this year at World Congress, seeing doctors like Dr. Birx and Lindsay, who's wonderful. I mean, she's been vilifying estrogen for how long now?
She's been fighting the fight for 40 years longer. She's a young thing.
She's a hoot.
Yeah.
She is full of energy.
We could have her on the podcast, but I don't know if she'd sit.
Yeah. If we had some wine and some glasses, it might be different. Anyways, that study that crushed things, and so that's where we had, at least you could have conversations that people that wanted to listen. We could talk about metabolism. We could talk about things that made sense with molecular pathways that have ended up being, we've been fully vetted and verified that, oh my gosh, we were right. If we follow the aspects of cell efficiency, what you do to improve the cell, you give and metabolic flexibility and so forth, you can't stop menopause, but you've certainly seen with many patients, we can delay it. And in fact, we can bring back, we can do things to prepare them even better, though, for when they have that opportunity to go on therapy.
Well, that's what I was saying too. Like, you might not, you're just making menopause more bearable for them.
Correct.
And
you want to make it seamless. You want them to have control. And I think that's the biggest thing. And you want them to be informed, to make their decisions when they're ready.
Yeah.
And
when are they ready? When should women start considering HRT? And if they are starting, what hormones specifically should they be taking? Because you're bringing up ratios before.
So what the study you referred to was talking about synthetic hormones, not bioidentical hormones like micronized progesterone and estrogens that are like estradiol, estriol, the bioidenticals. That study was looking at equine estrogen and progestins that were bad type of hormones to be utilizing anyways. So
it's like setting up for failure anyways.
In some respect. And taking an oral estrogen, wrong process, because you want to, right now, when you say the right type, it's micronized, it's really micronized progesterone orally, and transdermal or topical estrogen that gets that first pass, doesn't get the hepatic breakdown right away.
What about like testosterone for females? Is the topical better or the oral better?
Definitely topical.
Okay.
But the oral's coming, or it's here. It hasn't passed that. There's been the FDA approval for oral for males. The FDA approval isn't there yet for females, but it's the potential is there.
It's interesting the gap that continues to be present anywhere. Like, you can think of the fact that 50% of athletes are women, but when you consider the hormone treatment plans for athletes, those are all built around men. So like, what if, you're not someone who's menopausal yet, you're just someone who's athletic, maintain a good physique, exercise all the time? Like, what should a female athlete be considering when it comes to HRT?
Well, that can be even tougher because females, the problem there can be they have reduced fat, so they lose some of the aromatization of the testosterone to estrogen. So that's one. There are two ways they make estrogen.
Isn't it like that female athlete triad?
Yeah. Well, they call it a deficiency process now in sports. It's I can't remember the specific name, but they talk about deficiency in, and it's related to, overtraining, where they lose their periods, and they lose that tight control of estrogen and progesterone, and they also get into problems because of their training and potential overtraining and not a good enough nutrition. There's the aspect of how mitochondrial efficiency then plays a big role in creating. If you lose mitochondrial efficiency, you get reactive oxygen species that then affect the process of making hormones and also the release, the hypothalamic pituitary adrenal axis, and then you get into problems with cortisol that can have an effect. So they really, female athletes are even more difficult than male athletes, and you've got to really pay attention to helping them understand how training, especially where the training regimen and the nutrition are very important, and this is where I think you can do a lot of things to correct. We have a lot of ways in working with those particular people, and this doesn't have to be a high level athlete. These can be people that are just out there training, feeling like they're getting better, but yet they're losing efficiencies of their hormones. And they can't, because when that starts to happen, that's when they start to they're not getting the full benefit of the lean muscle mass, the mitochondrial density that they need. They're not building bulk, but they're building good muscle with more mitochondria. And they're starting to get potentially this influence on the osteoclast and loss of bone, which is not good at all. And that's what you want to avoid.
So what are some ways, just naturally or through everyday diet, exercise, and all that women can increase their estrogen, progesterone, testosterone?
Wouldn't like a simple supplement like arginine alpha ketoglutarate, isn't that something simple that anyone could do? It's good for you, but doesn't that help females regulate their hormones?
So it plays a role in biomass in the Krebs cycle. It does have a significant role in fertility and reproductive health in females. It works in recovery and repair. It works in collagen. It works in having more nitric oxide potentials. So it's something.
It's not going to be like, here you go, this fixes it, but.
No, but it's something that is easily depleted. You make alpha ketoglutarate through other amino acids, but as Matt said, if they're not doing the right job with the appropriate protein intake, they're not getting the right amount of sleep, they're overtraining, or they're not doing it enough for, it may be heavy in cardiac, but they've lost this, for some reason they've gotten away from resistance training, which is huge. I think that's underestimated, how significant strength training is in females. It's a big, big player. And if you can get the female population more focused on strength training, oh my gosh, you've really changed the dynamics of those athletes significantly, and we see that all the time in how it has an influence on making all the other things if we use certain peptide therapies or low or small molecules or certain supplements like you
What
brought
certain
up.
peptide therapies?
Well,
Name a few.
I think that's something that we deserve a whole nother episode.
Okay.
Just like, yeah, we're going to do it for the males. Females matter too.
But that's easy
Balance.
we could jump into, I mean, GLP-1s to improve metabolic efficiencies and flexibility, which we've already seen.
I feel like that's one of my favorite, like obviously I'm passionate about female hormones because I'm a female. But seeing,
You're a female.
I am a female.
Interesting.
Yes.
Okay.
Fun fact.
Yeah, thank you for clarifying.
Got you.
Yep.
So our patients who've been battling PCOS for who knows how long, just like hearing because they're always apprehensive at the beginning because doctors have told them like, oh, we'll fix this, take this, take this. And we just start them on the GLP-1. And sometimes it's within like a few weeks or like I had back-to-back cycles. They were regular. They weren't miserable. And it's just seeing like the light in their eyes, like, oh my God, there's hope.
So here, and I'll take that further in the young ladies that work with me in my practice. They've seen these changes. They've seen how important understanding the hormones are. And I've always said, boy, give me a shot. If you're young and in your early 30s, before things really start to hit you, let me do your hormone metabolites so I know now what you're doing so that I can use that in the future as a benchmark. Same thing with males. Like I've talked to you, you guys as younger men should get your testosterone level, your IGF level, IGF-1, I want to know more now because that is going to be so valuable to me as a baseline in the future. So you brought up, I think that's a whole new episode with the next step in even more complex issues with hormones with females and talking about the approach and the use of hormones and peptides. But peptides play a huge role for us in serving many, many different purposes of, number one, the ovarian reserve that they have. That's like the Noah's Ark. That's the gold you gotta make sure you're optimizing, and that's where inflammation and aspects affect ovarian reserve. And so you can actually do we have some peptides we can work on to assure that we're hitting that process of protecting the ovaries that are there. And then you look at, we can go higher in looking at the aspects of signaling, of what peptides we can use to improve possible gonadotropin releasing hormone from the hypothalamus or luteinizing hormone and follicle stimulating hormone from the anterior pituitary. So,
can I ask you a question?
Yeah.
What would you say to a physician who subscribes to if she's older than 50 years old, you don't start HRT? Maddie, what are your thoughts on that?
Bye.
Oh,
Like, why? What would their reasoning be?
It's just a popular benchmark that you kind of hear out there. Like if she's older than 50, don't start her on HRT.
And maybe you're thinking 60 or something, but
it's never
maybe
too
it is
late.
50. We don't think from the cellular medicine side.
Yeah.
That number keeps expanding, and we never think it's too late. I mean, we could talk to Siobhan, who has great experience in actually.
We're going to be talking to Siobhan in 2 weeks.
Oh, rewind that.
We'll have to potentially talk about that then, because.
Or no, 1 week. It's next week.
Because it isn't too late if you know how to approach it. Now, there's the window, they say the statements out there are you got to do it closer to, you're going to be more effective if you and cause less potential of problems if you approach it within the first 5 years of menopause and then maybe stretch it out to 10. But I'll remind you, if you're looking at all of the metabolic processes and you truly understand this metabolism, how estrogen itself metabolizes, and you understand cortisol and DHEA sulfate, and you understand, again, that hydroxylation, conjugation, and elimination aspect of these metabolites, I think you understand all the other stuff we do on cellular medicine to improve cell efficiency. Well, hello, you can do a lot. It's just you got to spend the time thinking through what are your steps, how are you going to start your foundation, how are you going to build it, and how are you going to get them prepared then to use these hormones.
I feel like, too, part of it's just like that mentality of like, okay, females, you carried a baby, birthed a baby, you gave the next generation, your body did what it needed to do, so like you can be done. I feel like that's part of the mentality of like an apprehension people have of getting started because they're like, well, my body did what I needed to do. This wasn't something in the past, so why should I be doing it now?
So speaking about what you can do now, what's today's performance protocol?
Be nice to females because we're hormonal.
I think today's performance protocol, I think females should be demanding an in-depth look.
I love that. The protocol is a call to action.
Yeah,
Ooh.
it's do your homework and find, I search out our people, our cellular medicine people that truly are going to look at all of these things and aren't just going to say, hey, take this.
I think it also has to be like, look at your metabolites because that's what's going to keep you safe.
Is there a specific test, or you just throw them to like Quest or LabCorp or something?
Dutch will do a good urine test.
Okay.
Yeah, they're and they keep refining. It's the most. I think it's the most.
Because it breaks down the pathways, so it shows like, okay, well, if a patient isn't metabolizing estrogen the way you want, we can fix it and work on it so that we can.
And we're talking about metabolizing estrone and estradiol and how it metabolizes into 16-alpha hydroxyestrone, 4-hydroxyestrone, and 2-hydroxyestrone, and how we want everybody metabolizing 2-hydroxyestrone, which is the anti-proliferative. It's good. And we'll get into that, I think, when we go back through everything. But I think it's absolutely a call to action because I think that's where I have a lot of I keep learning because I'm constantly humbled by the female population because when I think I got it down,
we throw another curve.
There's another curve that we got to figure something out of.
We just had that curve a few weeks ago in the office looking at one of the Dutch tests, and Grace actually stumped you for a moment.
What was that? What did she bring up? Do you remember?
It was all about the cortisol and DHEA and.
Well, she had it backwards. It was it's about responses of cortisol and DHEA sulfate and what makes up total DHEA, and she had it right. She just wasn't thinking it through.
He was stumped, though.
Well, I wasn't stumped. I was like trying to figure out what she was. Well, she had me questioning myself, I think, for a second. And then I'm like, no, Grace, because Grace talks with authority, And she's like, Doc, this is what you told me. I'm like, I didn't tell you that. And I'm trying to think through it. And then I'm like, I know the way you're thinking. Because you like to see real quick and dirty. As cortisol rises, you want DHEA sulfate normally will also rise because it has the immunogenic aspects of controlling cortisol and causing it to dampen back down. It has all these things, these interactions, but that's when it's all working right. But if cortisol has been chronically elevated, then you see a drop off of DHEA sulfate. And so she was trying to correlate it with good and bad, and she was thinking right, but she just didn't. She wasn't on the right path until we had a discussion afterwards, and she understood that, oh, okay, this is a chronic cortisol elevation. The DHEA isn't, you only get so much to respond to, and that has to do with production, and we talked about that. And then you lose that capability. So that's where sometimes utilizing DHEA as a supplement can be very helpful while you're fixing that. And you got to know the timing with that.
And we could talk about, when we do the next episode on female hormone like treatment, how DHEA can be really helpful for females as well to increase their testosterone.
Correct. Yeah. Another a beginning.
So I like this idea in the future here. We'll do like a whole treatments episode, really dive into the peptide applications as well. But I think this is a good place to wrap this up. This was a fun two-parter.
Yeah, I liked the two-part.
Threw it at me. It's a huge part of everyone's practice if you pay attention to it.
Yeah.
And I think with every female, if you can get to that discussion, they deserve to know what's happening there, and because there's so many parts and pieces, like how dysbiosis of the gut can play a role in elimination of estrogen. People don't really typically know that, and how the gut can disrupt and give you these problems with where, like I said, estrogen can look normal, and yet they're not able to eliminate it. So it gets recycled.
I feel like for females too, it's very important to walk through the process with them because it validates everything they're feeling.
Correct.
Because you can't see hormones, so they don't feel their best. They don't feel like they can't tolerate people, very emotional, and feeling like there's no reason why. It's hard. And so a lot of times during the consult, they're tearful. They cry and they're like, this shows I'm not losing my mind. And so providing them with that validation is huge.
Yeah, I mean, an easy step into that is why with females, selling can be so powerful, because they've lost, potentially they're in that early phase, or they've had something that's disrupted not getting enough estrogen to help with BDNF production. And we know now, with more of the literature confirming that brain-derived neurotrophic factor (BDNF) is so important in how it. If you're not making enough, you're going to have some serious issues with anxiety and depression and so forth. So it all plays. Again, it comes back to, if you know your cellular pathways, you know what a healthy cell is supposed to do, well, you can start to try to think and figure out what may be going wrong, and then get to root causes. And that's what it's all about.
That's what it's all about.
So I think this is a good place to end. Thank you for sticking with us on this episode. And I want to say, Matt and Maddie, and thank you for the female interpretation of what I have to say, and actually relating to what you have to deal with, and thanks for doing that.
Happy to help.